Thanks, Gordy. I appreciate the opportunity to speak to you today, especially presenting here in the home city. As we talk about with the presence of uniform in the room, what this really culminates for me as I come to the end of my military career is kind of the end of basically a decade of life work towards how do we prepare not just surgeons, and I realize it's geared towards surgeons, but how do we prepare and define readiness to go out the door? Because I will start at the outset that I think generally as a military, we're ready to be ready, but are we really ready? If we had to go out the door tomorrow, are we really ready? Are we ready at that point to get ready to go? And so the question is, how do we define readiness? What are those skills? And there are lots of groups working on this. There are lots of folks trying to define it. But in the end, how do we deliver it? And how do we deliver it with economy? How do we deliver it? And still sleep in our own beds at night and eat dinners with our families? And that's the challenge that I think that it presents to us collectively. And that's the theme for my talk today. I have no disclosures. So, readiness versus reactiveness. So, number one, what are the defined go-to-war competencies? Can we list what those go-to-war competencies are? And we can say, hey, we had to do 10 neck explorations and 10 thoracotomies and 20 laparotomies a year. I can't tell you the last time I had a chance to do an elective thoracotomy as a general surgeon, let alone for our cardiothoracic surgeons. Most military facilities we talked about have volume issues in terms of this overall volume and to sustain that trauma readiness. Here's the interesting thing. So the hospitals where we all work expect that the units that we're deploying with pay for that training, and the expectation exists in the opposite. So, well, I'm not deploying units. You should be paying for this training, and there's this the only folks caught in the middle are you and I, who are sitting in the audience or in front of you, who have to go out and deliver those capabilities. So in the end, there's this who's going to be the bill payer when it comes down to providing this training. So what inspired this? What inspired this process? So when your phone rings and you say, well, I'm deploying next week, and I haven't had a chance to do any training. Like, that's a problem. So what happens? Who's caught in the middle? Why does it happen? Late notice deployments, unable to get central seatings, change in deployment dates. Again, a very, very reactive process. So let's take that situation. What's the situation? So you're getting ready to deploy. You have had no training, so what are the three things that happen? Either we deploy providers without training, and in fact, conversation, yes, well, we just figure it out. Well, who are we figuring that out on? We're figuring that out on the soldiers that are laying in front, soldiers and sailors and airmen that are laying in front of us. The second option is, well, I'm not trained, so I'm not going to deploy. That means someone who's already there for 4.5 or 6 months is now staying longer. That's the second and third order effects of that are real. Or, as we've seen happen, I'm not trained. Well, I'm going to pull someone who is trained, and now at short notice, I'm going to pull them out of their practices, out of their homes, and I'm going to deploy. Now, we're all prepared to do that, but is this a good reason? And I would argue the answer to that reason, this is not a good reason. So, defining the go-to-war skill. And we're just going to kind of run down into how should we define the go-to-war skill. Now, again, this is taking a book out of General Places. This is Imad Haque's opinion in terms of how to define this. But we've struggled to define these skill sets. We've struggled to put them in a construct. And so my goal here and what I've been working towards is trying to define it into a construct that's deliverable and trackable and reproducible, so that we can set this up in major military training centers. These are all doable things. We have the skill sets and the capabilities to do it and provide the capabilities for readiness. So we look at our medics and we look at what the medical skill set should be. We've got tactical combat casualty care. We've talked about this already. The medical Table 8, and Table 8 is their validation exercise. So this is for Army medics, so I apologize for my Air Force and Navy brethren in terms of terminology. Prolonged field care, we talked about that as well today, a skill set that we have to absolutely expand when evacuation isn't 30 minutes away, but 30 hours away. How do we keep those folks alive in the field to do that? And then lastly, tactical triage. How do we decide when casualty rates are 50%, how do we decide who lives and who dies, and how do we apply those limited resources? Tactical triage. Now we extend that over to our non-surgical brethren, if you will, and then just in taking big groups. And we say that they need to have the same skill set, have to have the same tactical combat casualty care, because those medics or those corpsmen or those techs are operating under our licenses. We better be the experts at tactical combat casualty care. Advanced trauma life support, when that patient comes into a role 1 or role 2 or non-surgical role 3, better have the ability to run that trauma bed. Mastery of clinical practice guidelines. All the lessons we've learned over the last 20 years, if they're not mastered, they're wasted. Plain and simple. And then the bridge on prolonged field care from a provider perspective is do we have the fundamentals of critical care? And this is, again, not applying to surgeons, but generally to everyone who wears a uniform, who deploys, who may have to sit on a patient for 30 hours. How are we going to keep those folks alive? And then lastly, the fear of and I talk to my family practitioner colleagues or pediatrician colleagues, what happens when they face the mass cal? Nothing keeps someone up longer at night than understand that they have to face a mass cal situation. So how do we prep and train that, and how do we prepare teams for that? So let's look at surgery. Let's look at surgery. What are our skill sets? Because, okay, now we talked about the non-surgical skill set. Let's talk about the skill set. And what can we reproducibly offer on a repeatable basis, repetition, get the reps, and I'm not dependent on someone getting shot, down the street to be able to do this. What I can do is provide this on a scheduled basis. You block your schedule, you code it for readiness when someone's asking you how you're spending your time, and you spend your time getting ready to deploy if that's truly our #1 priority. So tactical combat casualty care, clinical practice guidelines. Do we know how to place the new technologies? Can we do the advanced trauma operative management? I'm going to give you a credential. REBOA, can we work with the new technologies? Ophthalmic, orthopedic, neurotrauma, all those things on the edges that we need to know how to do in the austere environment. The vascular and anatomic exposures, the asset courses, and the ability to take that mass cal and triage skill set from once the medics get them to us, what do we do next? And how do we decide to allocate that 1 or 2 OR beds, and who's going to the OR beds first? And then, finally, the process of the applied mass cal training, and how do you do that in simulated austere environments, or the simulated unexploded ordnance? So what is the thought process? If you've never thought about it, have never thought about processing how you solve that problem, it's not a problem you face until you're there and you're figuring it out all on your own. So the idea behind these exercises is to essentially give teams and give surgeons the opportunity to face all the things that we have faced and learned over the last 15 to 20 years. Do it in a standardized way so that both individual surgeons and teams have to process it, have to work and problem solve as a team, so when they find themselves in that environment, it's not the first time they're facing it, and there's not a real patient on the table who's bleeding to death or potentially dying. And then lastly, so lots of residents in the room, and there was a segment discussion of what are we going to do with graduate medical education. How many residents, and I'll tell you as a resident, when I deployed 3 weeks out of residency, how many times had I been in an FST or a CASH, and there were MASHs back then too, but how many times had I been in one of those and knew what it looked like? Hadn't. Yet the expectation is that we leave our residencies and we walk out and we should be able to function immediately at the highest level. Within 4 months of graduating, we should be able to translate our hospital skills into austere surgical skills. And I think those are again elements where we have to focus and use simulation for that purpose. For purposes of time, I'll run through very quickly. So I talk about the components of a four-pronged readiness system. The British have their most course. Well, I'd argue at Madigan we have more. You have to have a good name. So Madigan operational readiness exercise, that's what we're throwing at our non-surgical providers and our nurses. Our Master X is what we're offering to our surgeons, and it's in correlation with our operational units. So graduating chief residents are in forward surgical teams with forward surgical teams doing standard exercises, training together, learning the language, learning the instruments, learning the equipment, and learning the limitations before you're in the field. For our medics, we have to offer the same, and that's a whole other point of discussion, and we'll kind of put that to the backdrop here. And then lastly, how do we prepare our residents? And so that's our and I realize for Capstone means multiple things. It's like the course to become a general officer is also called Capstone, but I would argue that for our residents, this is their Capstone. leaving your residency, if we're going to be providing combat casualty care, how are we going to prepare you to do that? So very quickly, when we break for the non-surgical providers, we anchor it to ATLS, and the OE stands for operational emphasis. I don't need vanilla into bridge abutment ATLS. I need ATLS with an IED a vehicle that goes off the road hits an IED at 60 miles per hour with thermal, penetrating, blunt, and decelerative trauma. That's the scenario we need to be talking about, and those are the scenarios we offer in operational emphasis. Tactical combat casualty care, fundamentals of critical care support, MASCAL. It's a week. Book it, schedule it. And it's very predictable, and everyone knows exactly where you're going to be and where you're going to be spending your time. I'm preparing for readiness. This is my readiness. I walk out of here with 30 hours of CME or CNE, and so we start building the win-win-wins in the process. Every one of those instructors come out of your facility. So we maintain instructor status, we maintain certifications, we issue credentials. Master X kind of follows, and you'll notice there are a lot of acronym courses, but we pin them to certified courses. That is a competency. It is a credential. We talk TC3, ATOM, ASSET, the best for RIBOA, elements of emergency war surgery course, because there are excellent elements of that course, as I mentioned before, and then we put it all together. We put it all together with a MASCAL exercise, simulation, and then you got to decide who you're going to take to the OR. Who are we going to, of those 10 patients that come into a split FST or any austere surgical team, you only have one surgical bed, who gets it? And that becomes real decision-making process. It means someone may not survive. Someone may not survive in that process. TC3 we'll skip over for purposes of time, but it's the idea of how we train our medics. And then last I'd like to talk about is our capstone for residents, because there are a lot of residents in the audience, and we have program directors in the audience. And so how would you like to prepare? This is a quick overview, real busy, but you'll see on the pictures on the right, it's how many residents have been attacked in the room have been on a military airframe? How many have provided care on a military airframe? I got one. So so in that setting, or two, excuse me, I'm sorry. But yeah, but the idea being it's a small percentage, yet when you leave your residencies, you could find yourself in that situation really quickly. So our capstone event, which is actually in a couple weeks, and it mirrors that for what we did last year, is we're teaching folks tactical movement, we're getting folks ready with TC3, and then we're putting them in a scenario where they're doing this. So ever tried changing a tourniquet after decontaminating a patient? So that CBRNE risk, that's real. That's real, it's coming, we're going to see it, and we better know how to do it when we're leaving our training programs. Can you deliver care under fire? When you're the doc on the convoy, as you may find yourself, can you provide care under fire, tactical field care, call for your 9-line medevac, provide the care in flight, run the aid station bed, get the patient to an FST, do the ground transport, fly to an airfield, but now you can't get to your destination and you're stuck doing prolonged field care and trying to figure that piece out. Have the confidence to pick up your phone and call for help. All the telemedicine stuff, it's real because you can do it and the capabilities are out there. And then how much work does it take to put someone on a C-17 and fly them out of theater? Anyone done that before? And I look in the residents, well, yeah, folks that have done it. But it's hours and hours of work that folks don't understand leaving residencies. And so in the end, in a week exercise, all simulation-based, our graduate medical education residents, every single one of them, 72 residents and graduating interns, will go through this exercise, and in the end, have an opportunity to know this, integrate a nurse per team, and be able to see every echelon every echelon of care and the process of tactical evacuation care as well. So in conclusion, look, are we ready or are we reactive? I would argue that in the end, we're ready to be ready, but most of our readiness is in fact reactive. You get an order, now I'm getting ready. If we asked an infantryman that, so hey, I know you can shoot your weapon, but you're not qualified until we have an order to go to war, I would say I don't call that infantryman ready to deploy. Can't hit a target, hard to put him in combat if he can't hit a target. We create local readiness platforms. We do it at home. We try to centralize all these things. Expensive, it's travel, it's time away. So we do it at home when we build these local capabilities, and it's the cooperation with the hospital and the operational medical units, so those units are working together. Established in credentialing courses, so there's something to track. Can I track a certificate that we generate for a course, or is there a credential that a national or international organization can track? We can track those. Those are trackable credentials, and so we can tie credentialing to readiness. And then lastly, we're leveraging all forms of simulation and the importance of integrating it to GME curriculum so we can keep this process going and start it as for interns and residents, so when they're ready to go out and be leaders as captains and majors and on, they know where they came from, know how to apply it. As generations of surgeons that have deployed are now moving on, we have to pass on that knowledge, or it's lost. Thank you for your opportunity.